A very good afternoon to all. Thank you, Dr. Rajeshri, for giving me this opportunity. So, my double trouble with the Dicey Bacillus. It starts with a 63-year-old female patient who came with defective vision in the right eye of 1 week duration. There was no history of pain, redness, or headache. History of contact with tuberculosis was present. So, on ocular examination, the best corrected visual acuity in the right eye was 612 with defective color vision and a grade 1 RAPD. Anterior segment showed few cells in the anterior vitreous. Perimetry showed a dense superior peripapillary scotoma. Left eye was normal. So on fundus examination, the right eye showed disc edema with hemorrhages. There was macular edema with exudates and macular fan pattern. Indirect ophthalmoscopy revealed multiple subretinal elevated lesions in the posterior pole. Left eye fundus was normal. So the OCT macula confirmed the prominent disc edema with peripapillary subretinal fluid and intraretinal hard exudates in the papillomacular area. There was a large hyporeflective lesion in the choroid in the subfoveal area with the elevation of the overlying retina. Left eye OCT was normal. So fundus fluorescence angiography was done, which showed disc leak in the early phase with increasing hyperfluorescence in the later phases. There was no vessel leak or no leak corresponding to subretinal lesions. Left eye was normal. So here we had a case of unilateral neuroretinitis with a multiple choroidal nodular lesions in the posterior pole in a 63-year-old lady with a history of contact with tuberculosis. So first of all, we want to rule out ocular tuberculosis. Also, we want to rule out sarcoidosis, ocular syphilis, and choroidal mets. So the blood investigations revealed a lymphocytosis with high ESR of 65 and a positive MANTO and IGRA test. Serum ACE, TPHA, and HIV was negative. MRI brain with orbit was within normal limits. HRCT thorax showed fibrotic changes in the apical segment of both upper lobes with bronchiectasis in the right middle lobe and the left lingula. There was enlarged paratracheal lymph nodes. So chest physician consultation was done, who advised bronchoscopy with IBUS TBNA, but the patient was not willing. So with the COTS median score of 5 and an interquartile range of 0, ATT was started under the chest physician's care, with INH, rifampicin, pyrazinamide, and levofloxacin in place of ethambutol because the optic nerve was involved. Along with this, we gave systemic steroids at 1 milligram per kilogram in tapering dose. So in the initial follow-up, after 2 months, her best corrected visual acuity and the color vision came back to normal. The optic disc edema was reducing, and the choroidal lesion also was resolving. After 2 months of ATT, she developed jaundice with fatigue. A gastro consult was done, which showed 10 times elevation of liver enzymes with a serum bilirubin of 2.7. So viral hepatitis was ruled out and ATT was stopped. So in the follow-up in the 4th month, when she was not on ATT for the past 6 weeks, we saw that the choroidal lesion was increasing in the inferior macula. Again, start of ATT was asked for. ATT re-challenge was done multiple times, one with simultaneous with all drugs, then with INH and levofloxacin, which showed that INH was causing the hepatotoxicity. So in the 8th month, she was started on rifampicin and levofloxacin, initially with 300 mg, then increased to 450 mg for rifampicin. And during this time, the choroidal nodule was persisting. So after 6 months of ATT with rifampicin and levofloxacin, in the right eye, the choroidal nodule lesions elevation was still seen. Also, by the 13th month, we were seeing there's a new lesion in the nasal retina, and the macular lesion was increasing in size. There were also 2 lesions seen in the left eye. So now we advised addition of ethambutol in the ATT. So a baseline perimetry was done, which showed a subtle superior peripapillary scotoma still persisting in the right eye. Left eye was normal. So with rifampicin and levofloxacin with ethambutol, this choroidal lesion was resolving in both the eyes. So in the last follow-up on November 2nd, after 4 months of ATT with ethambutol, best corrected visual acuity and color vision are normal with resolved disc edema in the right eye and no choroidal lesions in both the eyes. So in a literature review, we found that our patient had a grade 3 moderate level of hepatotoxicity, and the possible regimens, whatever seen, all contain ethambutol. So my questions to the panel is, this patient had initial 2 months of intensive ATT therapy, then intermittent ATT in the next 6 months, then 2 drug ATT in the next 6 months, and 3 drug ATT with ethambutol for the next 4 months. So what are the suggestions to complete ATT in such a patient who develops drug toxicity or drug allergy? what should be the total duration of the treatment. According to the pulmonologist, we could stop ATT after these 10 months of therapy, continuous therapy. So, any similar experiences? And the opinion on addition of ethambutol later, was it a wrong?
I think I'll just try to summarize it in a single excellent, brilliantly managed case. But what I would have done, I would have started ethambutol from the beginning only. I'm a little skeptical of going into the levofloxacin related treatment, because if you see that there are sufficient literature that it should be used as a second line treatment. And we have to understand that we are always treating a latent tuberculosis. So sometimes we are not sure that how much infection we are dealing with. So we should not actually go and spread the what we call this resistance. No? So that is my primary concern. And we have treated a series of patients with optic nerve involvement ocular tuberculosis. I think it is more little bit of myth that if there is a optic nerve involvement and if we give ATT containing ethambutol, it will cause more harm. I don't think it is supposed to cause more harm. The chances, the risk will be same as you give a ATT to a normal patient only. One good thing about this is these are the patients we give little higher doses of corticosteroid that helps in resolution of the optic disc edema, not the ATT.
How you monitor ethambutol toxicity in these type of patients with optic nerve involvement?
Any patient ethambutol, like we normally what happens, we give it only for 2 months. So we monitor the patients regularly. We call the patients every month and just see them, and later we ask them for 3 months or
in the modified ATT regime, they are giving more duration, no, ethambutol?
Yeah, that I have spoken to my chest physician, so she's quite here, so she makes it.
Oh, only 2 months you are giving ethambutol. Okay.
Sir, before starting ATT, do we have to get an HFA, color vision, all those things done when we are for?
We don't do.
Nothing
LFT
of that.
we do.
That's all.
Just to see that baseline, better to have a baseline LFT, to see that whether it is going on.
And if the patient is on modified ATT, how you titrate the duration of ATT in a ocular TB? I mean,
we don't try to titrate the.
I mean, again 6.
Yeah. So what I feel in such scenario, no, it is the anti-inflammatory treatment which is playing the role. It's not the ATT. And you have to see that now evolving literatures are coming where we are treating the more hypersensitivity to tubercular protein. For example, one of our series is coming where we have predominantly used the methotrexate. Because even after completion of ATT also, you will see many of your patients in your clinic will come back with recurrence. So there was a time when we used to believe that if you give ATT, the chances of recurrence comes down. Maybe it is partially true. If you complete the ATT, I think the chances of recurrences reduces, but still the chances of recurrence is there. I think Dr. Neetu is here, who was a part of our the SANTU study. There we used a lot of immunosuppressive to control the immunosuppression. Sometimes it was used by our colleague as a first line treatment also, and sometimes to prevent the recurrences also. So in cases of recurrences, I think it's better not to titrate the ATT. You have to think that how you can modify your anti-inflammatory doses. Like if it is oral steroid, if the patient is on oral steroid and in spite of 20 mg of oral steroid there is recurrences there or inflammatory activity is there, better not to blame the ATT. You have to think about adding an additional immunosuppressant.
And once ATT is stopped and then again coming with inflammation, so you are giving steroids or immunosuppressant?
Steroid and immunosuppressive, absolutely there is no role of ATT after that.
Okay, so the take-home message of first case is always suspect tuberculosis. History is again important. Like in this patient had a TB contact and all the tests positive. So do a thorough workup and monitor the ATT for liver side effects and modify the treatment accordingly and monitor the inflammation and treat the inflammation with steroids. Okay, thank you, Dr.